Hello, everyone, and welcome to today's episode of Knowledge for the Future of Athletic Training. I'm Kellyann, a first-year graduate student in the Masters of Athletic Training program at North Central College. I'm so excited to discuss a topic important for the future of the profession of athletic training, which is third-party reimbursement. Athletic trainers play an important role in healthcare, but with reimbursement for healthcare services athletic trainers provide, there's still a barrier. Today, we're going to talk about where the profession is at, where we are going to try to go, and what we need to do to change, and what's going to make the change happen. Joining me for this important conversation is a true leader and advocate in this space, Mr. Joe Greene. Joe is the CEO and owner of OrthoVise and is part of the National Athletic Trainers Association as a Payor Advocacy and Regional Coordinator for the District 7, 8, and 9, where Joe has been advocating in the movement for third-party reimbursement. He brings an abundance of knowledge and experience, and I'm excited to have him here today. Thank you, Joe.
Yeah, great to be here, Kellyann.
So for our listeners, let's start with third-party reimbursement and how it affects athletic trainers, kind of like what it is, just so there's no myths or common misconceptions that are lingering around.
Sure. So third-party reimbursement at a high level simply means there's another party paying for the care of a patient and the services that are delivered. So in our case, this is insurance companies with athletic trainers and looking at the types of services that we can deliver as athletic trainers that are reimbursable by those companies. And we do talk about government payers, workers' compensation payers, commercial payers, PPOs, HMOs. They're all kind of in that bucket, but all have kind of some unique characteristics about them.
And then just some of the maybe myths or misconceptions or things that people don't generally understand is I know when it comes to third-party reimbursement, when we're submitting for those services, whatever company we're working for, usually negotiates a price for us to be like, if you do this amount of 1 unit of therapeutic exercises, this is the X amount of dollars you're going to get back. I know with our realm intertwining with interprofessional relationships with like PTs, PTAs, OTs, is there a gap in what the reimbursement is for athletic trainers compared to those other professions?
No, that's a great question. And there are subtle differences between the type of facility or practice that you bill out of. So I'll start there really briefly. So if you're working in a health system and certainly some large outpatient rehabilitation practices, you are billing with likely a facility NPI number. And essentially what happens when you do that, you're not billing with your own NPI number as a PT, an AT, or an OT. You're billing with that hospital's or that large practice's NPI number. So when you do that, your organization has created a contract with all the insurance companies that they work with, and they establish a price for the services that they will pay. And so that price is distributed across all of the providers, and it's really at the code level. So if they agree to pay for a certain physical medicine or rehabilitation code, which they would in the outpatient therapy space, we encourage, and what we've seen adopted is that the only codes that are different in that space are the evaluation codes. And so we expect that they would pay an AT evaluation code at the same level as a PT evaluation code. And it's really if you look at the codes, they have different numbers, but the description of those codes are exactly the same. So that contract will pay a certain price for that code, a percentage of what was billed. And the same is true of all the other 97,000 series of codes, which are your therapeutic modalities, therapeutic exercise codes that everyone can use. So the only codes that really are different are those eval codes. When you do step in to a smaller independent practice or a solo practice, you will need to become independently credentialed and contracted with those insurance companies. So there is a difference between working in a health system or a hospital versus an independent practice that is smaller, because they will credential you as a provider and also agree to the amount that they will pay you for a given service.
And then I know since we're going into outpatient versus inpatient sort of talk, I know there's a little bit of like barriers and pushbacks when it comes to insurance companies, specifically with Medicare and Medicaid. So I know Medicare and Medicaid don't reimburse for athletic training services. just because Medicare is for 65 and up users, and they don't normally see Medicare users as the physically active individuals. Just because I know in the state of Illinois, for the licensures, we treat physically active individuals, and for Medicaid, I know that is usually for anybody who is on some sort of disability, temporary, or for low income, but they can still have people who are physically active individuals or who are competing in athletics. So what's kind of our step going forward with that, or what are some of the ways that we're trying to combat them, just because they won't reimburse for athletic training services?
Yeah, it's a great question and a very important one. When you talk about an insurance company that sets the standards in the United States for payment, and not to say that every insurance company has to follow what Medicare does or CMS does, but many do, and many employers often do as well. So Medicare establishes reimbursement for all types of services, including the services that we would commonly deliver as athletic trainers. Importantly, those services have to be medically necessary, first of all, meaning that we should not bill in our patient population, which is really common, for return to sport activities, for performance enhancement activities, for maintenance therapy, those types of things. So that's an important distinguishing factor of Medicare. And we align with that at the national level philosophically, is we want athletic trainers to bill for the right things that are going to have the greatest chance of being reimbursed and are also going to keep athletic trainers out of trouble. So when we talk to a commercial insurance carrier like a Blue Cross Blue Shield or United Healthcare, that is our messaging to them, is that we want to align with Medicare and Medicare policy and process, even though we're not recognized, because that's what they're used to paying for. And we're trying to advocate and convince them to recognize us. So going back to Medicare, just at a higher level, when Medicare decides that a pharmaceutical or an implant or a device or a certain type of procedure will be reimbursed, it's really important to understand that decision has a trickle-down effect to all other payers. So if they recognize, it's usually only a matter of time before the other insurance companies decide that they're going to as well. So a process to become approved by Medicare is also one that is fairly substantial from a human resource perspective as well as a financial perspective. It's a very important one, but it is something that currently right now the NATA and its leadership are requesting a meeting with CMS to talk more about this and what does that process look like, essentially, with the goal of eventually attaining Medicare recognition. We will never see a high percentage of patients that are Medicare eligible. But to say that a 70-year-old physically active golfer or a runner or a biker or a tennis player isn't something that we can treat, provided they don't have a lot of other comorbidities and things like that, is also inaccurate. So we want to be able to treat the Medicare patients that fall within our scope of practice. We know the positive trickle-down effect, but so do some of the organizations that might be concerned with us delivering some of this type of care. So Medicare is really important. One other important thing to note is Medicaid does not have to follow Medicare guidelines, but they do have to request in their budget to the federal government, to CMS, that they would like to cover other services that maybe CMS doesn't. So Medicaid doesn't have to, but right now they often do. So, but we have been making some progress with respect to the education of centers for Medicaid and the Medicaid directors within a handful of states.
See, I was unaware that Medicaid didn't have to follow Medicare, because I believe we were talking about it in class, almost like they went hand in hand with how they did their third-party reimbursement activities, but I didn't know that they were separate, just almost like other insurances like Blue Cross Blue Shield, United Healthcare, and other insurances as well. Yeah,
they commonly do. But there are many different types of services depending on the state that if Medicaid includes it in their budget to the federal government and that budget is approved, Medicaid can have a differing coverage for certain types of services.
So then for like the future efforts of trying to get third-party reimbursement for Medicare and Medicaid,
Yeah.
are you tackling each type of insurance differently? Because since Medicare doesn't have to follow Medicaid, would there be, I'm going to go try to get Medicaid first and then try to
Mhm.
go and see if Medicare would be willing to also reimburse for athletic training services?
Yeah, I think we need to work from both directions is the best way to think of it. Is the work of the NATA and my team and individuals at the state level are to try and secure as many insurers as possible. Because if we have as many commercial insurers and work comp and even Medicaid approved at the state level, that will be meaningful with Medicare at the federal level. Um, so I think we know that if Medicare recognized us tomorrow, these decisions with Medicaid and with all the commercial carriers would be a much easier one for us to achieve. And that would be really positive for athletic training and for entrepreneurs, where we'd probably be really busy implementing these things correctly. But I think we're working from both levels. And I think it is really important to appreciate that outside of Medicare and TRICARE, which is the military's insurance company that often reimburses for military members, veterans, and their families, those are federal insurance plans. All of the other decisions are made at the state level because insurance companies are licensed to deliver care at the state level. So Blue Cross and Blue Shield in Illinois versus Anthem Blue Cross and Blue Shield across the border in Indiana and Wisconsin, each would have to say yes. So the long and short of that is that I need help at the state level too. We'll work at the federal level, but I need individuals at the state level, at the association level for athletic training, much like a lobbyist in governmental affairs, to help lobby insurance companies to say yes at the state level, as well as the employers to use athletic trainers as billable providers.
And then I know we're talking about some of the different pushbacks, and I know we're focusing a lot on the insurance companies, but when it comes to like patient care, I know with third-party reimbursement, there's obviously units that you bill for, and there's certain ways that you can bill for things. And I know CryoConnects is one of the big things that we talked about when we were going over different modalities with athletic training and how it's really good evidence-based practice. But from what we see with the insurance companies, it doesn't look like CryoConnects gets reimbursed at a high rate, even though there's a lot of evidence-based medicine with it. I was wondering if you could kind of talk about when it comes to reimbursement, but there's a lot of evidence-based practice about it with not being reimbursed that well, even though I believe reimbursement is shooting for, we continue to pay for what you're doing if there's a lot of evidence-based practice and showing improvement with it.
Yeah. Yeah, there are certainly codes and different types of external applications that you might apply that insurance companies are going to pay for much better than others. Usually modalities are one of those areas where, especially over the last 30 years, we've seen a lot of decreased recognition of and outright denials to cover those things, where they will pay for manual therapy and for therapeutic exercises and for functional types of activity. So I think in the end, when we're talking about those types of services or types of treatments that we're delivering, the companies that provide those products are also trying to lobby insurance companies for that recognition, and it's a challenging marketplace. So precedent is really important. When I was delivering care in an outpatient rehabilitation environment in the 1990s, working alongside PTs, insurance companies pretty much paid for everything. They paid for heat treatment. They paid for cold after you were done with your treatment regimen, and pretty much everything in between. But that has really shifted to what they pay for. And I think we have to keep lobbying for this evidence-based recognition. But in the end, the insurance companies drive a lot of those decisions. And this evidence-based isn't specific to modality type care like you're describing. It's also simply towards us as being qualified, educated providers who can deliver this care under our scope of practice. And that's some of the things that we're working on as well is providing evidence that we can be effective cost-effective providers in this space when we work within our scope of practice.
Has with recent lates of just changing with economics and whatnot, has that been impacting how third-party reimbursement has previously as well as now?
Meaning the evidence behind it?
Are they reimbursing less for services now than they were prior?
Yeah, definitely. Yeah, especially the types and amounts of services that were delivered in the 20, 30 years ago. There aren't as many of them reimbursed, or they reimburse them at a much lower rate than what they used to. So, even well-accepted services, if you're a PT or an OT, so PT evals and all of the care downstream after the eval, the reimbursement rates have diminished over time. And so some of that is driven by Medicare, and what they pay for and what isn't within their therapy cap. But I think it's certainly become more challenging to secure the type of payment that we used to have.
Do you still think that we're heading in the right direction for the future for third-party reimbursement with athletic training services, even though they are reimbursing less now than they were before?
Mm-hmm. I do, for a couple of reasons. So first of all, I think when you enter the world of reimbursement, whether you're the athletic trainer or your employer's billing for you as an athletic trainer, is you have to become astute at the types of services that will be reimbursed and making sure that you are documenting correctly so you're securing all of the reimbursement that you can. The second piece is some of these insurance companies pay incredibly well. Work comp payers are the best payers, and they usually like athletic trainers. With work comp, you can distinguish a work comp patient in that you can take them all the way from their work injury all the way back to when they're working again. With an athlete, let's say if you have an athlete who's a 16-year-old girls soccer player who tore their ACL, that insurance company is probably going to cover the care from like 0 to 4 or 5 months, somewhat subjective. But when they've returned to activities of daily life, when they start training for return to sport, that commercial carrier like Blue Cross and Blue Shield or United or Aetna or Cigna is going to stop paying for that. And they would with a PT too, but there are so many athletic training patients who are in that world of return to sport. So I mentioned work comp because they almost always say yes to us if it's a state work comp payer, but they're also a great payer. And they like the way we function as athletic trainers because we're trying to get people back to work as soon as possible, as safely as possible, and so they don't have a new injury because then they don't have to keep paying work comp benefits. So I think that's why we've received pretty positive recognition from them. But the other piece to this, Kellyann, is more of a philosophical and a personal one to me, is the only reason athletic trainers can't work in rehabilitation departments or sometimes can't work in physician departments is because of a business decision made by insurance companies. So I want athletic trainers to have the choice to be able to work in these types of settings if they want to. And being able to be paid has been restrictive. We can't even be considered by a rehabilitation director in a hospital in many areas because the payment is ambiguous, or they know we're not going to be paid as athletic trainers. So that's something that I wanted to work to change because it's one of the few areas where we can deliver this care in our Practice Act. It's not against state law. You can make those decisions to treat these types of patients at that level, but we can't get in a position to do it because insurance companies don't recognize us.
I know in our class, we actually get special guest speakers every once in a while to kind of give us like an eye-opening of here's a setting that you as an athletic trainer or when you become certified that you can be a part of. And one of the new opening fields was working in a physician practice in a couple different positions. And they were showing that I guess our orthopedic doctors and our sports medicine doctors really love working with athletic trainers since they usually are working with athletes all the time or they're working with people who are the physically active individuals, and that they're trying to get like their insight and what they think would also help be like, hey, I'm thinking about doing this. for this concussion protocol, what's your options on that? Because as you know, athletic trainers are very educated when it comes to concussion protocols or like
Mhm.
exertional heat and illness or other, very sports medicine related research. But
Yeah.
it's really nice to see that you're trying to make it so we can get into those physician practice, just because it looks like those doctors that are in more of our specialized areas are really appreciating the knowledge and that skill that we bring to the table, even if it's not like one of our traditional settings.
Yeah, I was involved in physician practice settings really early in my career, as well as outpatient rehabilitation, and that has really grown organically. So the NATA certainly supports it and wants to help it grow, but it's really because of a mutual interest between the physicians, whether they're a primary care sports medicine doc or an orthopedist, and athletic trainers wanting to work in that type of capacity with them, that it's grown. So that's been really cool to see. I think in many ways, the knowledge and the skill set that athletic trainers brings to a sports medicine or orthopedic physician setting drives productivity enhancement. It drives patient satisfaction. The physicians love it. Once they implement it, I've basically never seen athletic trainers leave that area. So like I've been involved with some entities like Duke and with Emory, who started with one athletic trainer and now they have 50, so I do think in some ways it's driving the real or perceived shortage of athletic trainers. There's a lot of interest in this setting on both sides. And are there enough people to fulfill all that? So just one other comment on that space is I think, as I mentioned, productivity is a huge driver. If a doctor can see 4 to 6 more patients a day, which has been proven actually in some literature that's out there, because they have an athletic trainer working in their clinic, that's usually really important to docs. But there is the ability to bill when athletic trainers are employed by the same group as the physician is, and that's kind of billing in alignment with Medicare's Incident 2 process and policy. So you can bill for brace fitting, crutch training, gait training, therapeutic exercise in the clinic. There's always a balance of, do you want the athletic trainer spending a lot of time on that versus seeing another patient? But there is the opportunity to bill. And when we pursue CMS, we want to be recognized in an Incident 2 style capacity too. So we could treat Medicare patients alongside physicians and bill for it. So right now, commercial payers will allow us to bill under a physician at the time of treatment, but we can't do that with CMS patients. So, but yeah, I think productivity is great in that space, but there is the opportunity to do some billing in that space as well.
I think that's a great space for athletic trainers to get into, even if it's like them as a new grad or somebody who is a very skilled, has been in the game for like 20 plus years or something. Then I think it's a good setting for them to get in, because it's something different, something a little non-traditional. And I feel like it really helps with the advocacy, since we usually work very closely with a physician anyway, since they oversee the licensure. So I think it's a really good connection between interprofessional relationships with your MD and with athletic trainers.
Definitely.
And then just some advice for either athletic training students or newly certified individuals, or even people in the athletic training game. How would you kind of recommend them or advocate for them to kind of get involved with third-party reimbursement?
Yeah. I think this is my opinion, and what I've seen has been successful over time, is as I mentioned earlier, the NATA supports this philosophically. Myself and individuals who work with me can go out and educate employers. They can educate state associations, but I need people to get involved at the state level. We will advocate with CMS, as that progresses in the future, but I need an individual at the state level, like a governmental affairs chair, who will be essentially a reimbursement chair, who commits to this for the long term. Like you will always have in Illinois a governmental affairs chair. I need the same in the reimbursement space if we're going to make meaningful, sustained progress. So I would say get involved at the state level, learn. We're willing to help. express interest to me or my team. But really, the progress, I think, is going to be driven by state associations. And that's no different from the physicians who are in a state medical society in a state. They call it the APTA of each state. Represents them in the same way with insurance companies. And so we need to have that at each state level as well. So get involved at the state level with reimbursement. That's probably the best way to get started.
Perfect. And so I'm just going to summarize some of our key points. So obviously some of the misconceptions with third-party reimbursement we addressed with that. When you work with outpatient versus inpatient, you're either working with a hospitalized NPI code or you're working with your individual NPI code, and you can either get reimbursed at the same rate with that inpatient, and then that outpatient, you use your own NPI code where your company will negotiate prices for you. And it looks like work comp is very supportive of athletic trainers with getting their industrial workers back into their job in a very quick and efficient way, without like causing any future injuries. And then as well as some of the misconceptions with like Medicare and Medicaid, that they are not tied together, but we can go after each one of them separately and advocate for that reimbursement that we should be able to provide for those physically active individual based off of our licensure. And then as well as just kind of having the advocacy. So we all need to go for like the state level, help out and make it a change. It's not something that's going to change the whole profession as a whole. There's still going to be our traditional settings of working with college athletes, working with those high school settings, working with our industrial athletes. But it is a good way for us to stay in an interprofessional relationship with those other healthcare providers that are providing services as well. And then Joe, I know you might have something to promote as well. Go ahead and let's see what we can help out with it.
Yeah, no, I think it's important for individuals at your stage of your careers or education to understand that the NATA is resourcing all of this. And to that end, we are trying to work with states more closely and in higher volume. So we do offer what we call a third-party reimbursement boot camp, which is a 5 to 6 hour boot camp with multiple presentations that talks about what the NATA is doing, how states can support this. It talks about appropriate services to bill for, how to document for them. But it's something that we deliver to state associations and their leadership. So we have done that in Illinois, where you are, and we might do another one at some point in the future, but we are beginning to work and advocate with insurance companies there. So, so just a pitch for that, but mostly a pitch to help everyone realize how important it is to get involved at the state level if we're going to make progress on reimbursement.
And just to touch on that, yes, Joe has been to North Central College and has presented his boot camp back in 2022. And my program director actually still had your presentation for that. And I know third-party reimbursement can be such a confusing like topic for new graduates or even like student athletic trainers. And when she went over your presentation a little bit with us to let us see it, it clicked a whole lot more about third-party reimbursement for us, because I believe a little bit of a misconception is there's a lot of like red tape and like it's too confusing and it's a lot of hard work. But once you really understand it and you're given like that information and it's explained to you in such a simple way, it is a lot easier to understand. So I will say, if anyone needs a third-party reimbursement boot camp, they should definitely contact Joe.
Definitely. Yep. We've done 14 of them so far and probably have another 4 lined up over the next few months. So
hopefully that helps with some of like the new graduates or even with like people who are still going through grad school to kind of help spark the idea of like already getting started in the advocacy for athletic training services being reimbursed with third party. And then, so this would conclude our episode of Knowledge for the Future of Athletic Training. I want to thank Mr. Joe Greene again for joining me today and sharing the valuable information on third-party reimbursement and how it impacts the future of athletic training.
Thank you very much. Let me know if I can help at any time.